And thanks to everyone for joining. We are really excited to spend some time with you this evening. It's September, so it's Gynecologic Cancer Awareness Month. So we really, really love to meet and talk about what's going on in the gynecologic cancer space. So we have a wonderful group of physicians to give you updates on what's happening in their spheres of expertise. And one thing that I think is really exciting about tonight, it occurred to me that everyone here has been with NYU for many years, which is really interesting because we can really get into not just what changes we've seen nationally in our field, but also locally and kind of how we've moved the science here, even at our institutions. And so please feel to ask us about that during these, after you see each presentation. So as you can see, we've got an exciting agenda tonight. I won't go through all of them, but to start with, we have Dr. Edward Jiménez. And Dr. Jiménez is a board-certified gynecologic oncologist. He serves as the division chief of gynecologic oncology at NYU Langone in Long Island. He is a masterful surgeon, but also works in multiple clinical trials, assessing targeted therapies, cancer vaccines, and immunotherapy. And as I said, he's been at NYU Health for over 15 years and has been a treasured colleague throughout that time. So without further ado, Dr. Jiménez, looking forward to your talk on advances in gynecologic cancer surgery.
Thank you for joining us. As Dr. Boyd mentioned, September is Gynecologic Cancer Awareness Month, and this is a month where we aim to raise awareness about what's happening in GYN cancers, like Dr. Boyd mentioned. We aim to talk about screening, new treatments, and better ways to manage our patients. So today, my role is going to be talking about some updates in surgical management of gynecologic cancers. And I would like to focus on reviewing key surgical changes with respect to the management of cervical cancer, uterine cancer, ovarian cancer, and vulvar cancer, and describe what these changes have meant for our patients in terms of cancer outcomes, safety, recovery, and fertility. Some of the biggest themes over the past 2 decades have been talks around whether using less invasive surgery when safe, and that is specifically talking about laparoscopy or robotic surgery, smarter lymph node checks, the advent of using sentinel nodes in GYN malignancies, some refined choices for the management of ovarian cancer patients, with respect to the radicality, how extensive operations are. The timing of surgery has evolved over the years. And more recently, we've introduced newer ways of delivering chemotherapy at the time of surgery for ovarian cancer. And last but not to be missed is some progress in fertility preservation. So I love this slide because Sir William Osler is considered by many to be the father of modern medicine. He lived from 1849 until the early 1900s, and he was one of the most influential physicians. He emphasized compassion, listening to patients, and he has this quote that I love: "Diseases that harm call for treatments that harm less." And that really is at the core of what we do as GYN oncologists, what Dr. Lymberis does as a radiation oncologist, and what Dr. Sarah Lee is going to be talking about, some of the medical treatments for gynecologic cancers. So over the years, these treatments have evolved, and there's been a lot of progress in trying to deliver better outcomes and potentially decrease some of the side effects and toxicities that may harm patients. Perhaps most important at the core of this has been the evolution of minimally invasive surgery. And minimally invasive surgery in the GYN world refers to vaginal surgery, laparoscopy, and robotic surgery. And over the years, we've seen an evolution starting from these big open cut abdominal surgeries that in medicine we call laparotomies to less invasive procedures. The first laparoscopic hysterectomy was actually described in 1989, and it became more common use for the management of endometrial cancer in the 1990s. In the early 2000s, robotic surgery came along, and it was approved by the FDA for GYN GYN surgery in 2005, and we started using it for gynecologic cancers in the mid-2000s. What is the advantage of minimally invasive surgery for US patients? Well, smaller incisions, less pain, fewer complications, less blood loss, shorter hospital stay, lower risk of wound infections, faster recovery. You can get back to your families quicker and less scarring. So one of the questions has been, well, is it safe to do minimally invasive surgery to manage gynecologic cancers? And we have some data to substantiate that, particularly when it comes to endometrial cancer. I won't bore you with the details, but this is a sentinel trial. It is actually the largest randomized trial comparing laparoscopy to open surgery for endometrial cancer. It included over 2,500 patients. And this study was comparing whether it was safe, so looking at morbidity and mortality, complications, and looking at cancer outcomes. And this study found that at 3 years, the risk of recurrence was no different between laparoscopy and open. And looking at survival, they were essentially identical between the laparoscopy group and the open group. So this was very reassuring. One of the findings of this study, however, was that in about a quarter of the patients that started off as laparoscopy, that surgery had to be converted to open surgery. And this was more common in patients who tended to be a little bit overweight. Robotic surgery, since it came along in the early 2000s, the results of clinical trials have mimicked similar results, showing no difference in survival, faster recovery, less complications. But one of the advents of robotic surgery, what many trials have shown, is that the ability to complete the procedure minimally invasively. In other words, the chances of starting laparoscopically and having to convert to an open procedure seems to be consistently lower when we use robotic surgery, particularly in overweight patients. Another trial looked to compare, similarly, laparoscopy versus open surgery. This trial was carried out in Australia, New Zealand, and Hong Kong, and it included over 700 patients. And again, it was reassuring, showing us that survival was no different, highlighting that it is safe to do minimally invasive surgery for endometrial cancer. Now, based on those reassuring results, we began to use MIS. We expanded the application to other cancers that require hysterectomy, like cervical cancer. And this was based on smaller studies that had shown reassuring effects, but then came along a large prospective randomized trial. This is the trials that we consider as doctors as level 1 evidence. These are trials that sometimes lead to practice change patterns. And one of these trials was published in the New England Journal of Medicine in 2018. It's called the LAC trial, which stands for Laparoscopic Approach to Cervical Cancer. This was, again, a large trial that enrolled patients from 2008 to 2017, and eligible patients had early stage small cervical cancers, and they were randomized to either open surgery for their radical hysterectomy or minimally invasive surgery. And minimally invasive could mean either laparoscopy or robotic surgery. And the primary outcome of this study was looking to see, is survival no different between the two groups, just as we showed in endometrial cancer. To our surprise, this study yielded some results that we didn't expect, and it led to a lot of controversy and a lot of media coverage. What did the study show? The study showed that using minimally invasive surgery for radical hysterectomy in the management of cervical cancer, those patients appeared to have a little higher risk of recurrence and a lower survival compared to patients that underwent open surgery. This differed significantly from what we had seen in other historical studies. Now, why did this happen? The study was not powered, was not designed to look at that, but one of the questions has been, maybe is the technique, the approach, the manipulator use, is it make a difference? This was a study that involved 33 centers around the world. Does the expertise of the center matter? You know, the technique, does it apply to really small tumors that we know that we can usually cure? What we call low-risk cervical cancers, that is tumors that measure less than 2 centimeters. So this study left us with, we have to counsel patients carefully, and maybe minimally invasive surgery is not appropriate for every cervical cancer patient. And it left us with some questions trying to answer why we found this unexpected result. 2 recent clinical trials have looked at low-risk early-stage cervical cancer, and they have asked the question, is less radical surgery safe? And these 2 trials were recently published. One trial is called the SHAPE trial, and this again looked at really small early-stage cervical cancer patients that we consider low risk, so tumors that are smaller than 2 centimeters, where the cancer cells have not invaded into the vascular spaces or the lymphatic channels, and it compared simple hysterectomy to radical hysterectomy. The second trial, called a CONSERVE trial, similar type of patients were enrolled, and it compared cervical conization or simple hysterectomy to radical surgery. And what these studies showed is that the SHAPE trial showed that simple hysterectomy was not inferior to radical surgery in preventing pelvic recurrence, and it was associated with a lower risk of urinary complications. And the CONSERVE trial, the results of that trial showed that conservative surgery may be a viable option for select patients with early stage, low-risk cervical cancer, and it offered a fertility-sparing alternative to radical procedures. At our major cancer center, we're one of the centers that's enrolling patients in this clinical trial called the ROCK trial, which is actually looking at the use of robotic surgery for the management of early stage cervical cancer. And we're looking again at these low risk patients with some modifications which we believe may help to decrease the risk of recurrence and potentially may change what we saw in the LAC trial in terms of survival outcomes. Moving on to sentinel lymph nodes, which have been in use for GYN cancers over the past 20 to 25 years. So what is a sentinel lymph node? A sentinel lymph node is the first lymph node into which a tumor drains. How do we do it? It involves injecting a dye into the tumor or around the tumor, and that dye helps us locate the sentinel nodes during surgery. The sentinel nodes are then removed and they're sent to the pathologist to do something that we call ultrastaging, where the pathologists can do very specific testing on those lymph nodes to tell us if they're involved, and they can detect lymph node involvement that is so small that you would otherwise miss. What are the benefits of doing sentinel nodes? Well, the benefits are that we are able to preserve functional lymph nodes. We have thousands of lymph nodes in our body. It decreases the length of surgery. It has been shown to decrease the risk of short-term complications like seromas or infection. And it may decrease the risk of long-term complications like numbness or lymphedema, which is shown here, which can be quite severe and can be lifelong and really impact our patients' quality of life. The more lymph nodes that are removed, sometimes when we combine that with other therapies, can lead to debilitating lymphedema. And you can see here the increased severity from left to right. So again, this illustrates how we do pelvic sentinel lymph nodes. Essentially, what we do is we inject the dye into the tumor, and then we follow these channels that lead to the lymph node, which we can identify using infrared cameras. And I want to just briefly show you what that looks like live. This is an example of a robotic surgery where we're able to see the anatomy very well. We can really zoom in on the area that we are dissecting. This is a patient with endometrial cancer, and we're really zoomed in, and you can see that channel leading directly to the lymph node. This is the area where we injected the uterus, and we can follow those channels and remove, and you can see that we're able to remove these lymph nodes quite efficiently. So do we have evidence that doing these sentinel lymph nodes is safe? And does it give us the information that we need? One of the best trials looking at this is called the FIRES trial, which is a multi-center trial that looked at patients with endometrial cancer, early stage, that underwent sentinel lymph node mapping using a dye that we call indocyanine green, or ICG. What this trial showed us is that a negative sentinel lymph node was accurate in more than 99% of the cases. We call that a negative predictive value. And only 3% of patients with lymph node involvement will have their disease unrecognized by doing sentinel nodes. This is comparable to other disease sites that use sentinel lymph nodes, like, for example, breast cancer. So for us as oncologists, the results of this trial are reassuring because it tells us that doing sentinel lymph nodes is accurate. It helps us identify patients who may have more advanced disease and may benefit from additional therapies with less morbidity. This study included all comers with endometrial cancer, not just patients with lower grade tumors, which are less likely to be aggressive, but it also included patients with really high grade tumors that can be aggressive and have a much higher risk of spreading. It included up to 29% of patients with these high grade tumors. And it was reassuring to see that even for those more aggressive high grade tumors, the sensitivity for detecting lymph node metastases using sentinel nodes remained very high. And we missed very few of those patients with involved nodes. Now, this sentinel lymph node technique has also been applied to the management of cervical cancer and also to the management of vulvar cancer. Results looking at cervical cancer are similar to endometrial cancer, and the injection and dissection is similar. So I didn't want to show you that in another slide, but I do want to briefly show you what we do for vulvar cancers. And in vulvar cancers, the status of the lymph nodes, the vulva drains into the nodes that are in the groin. And the status of those lymph nodes in the groins is the most important prognostic factor for survival in vulvar cancer patients. However, only a third of the patients with early stage vulvar cancer have lymph node metastases. What that means is that approximately 2/3 of patients who have a full lymph node dissection may be subjected to a procedure that is associated with higher morbidity, higher risk of infection, wound breakdowns, higher risk of lymphedema, those pictures I showed with the swelling in the legs. And 2/3 of those patients may not need such an extensive dissection. So hence the value of considering doing something less extensive, less radical, like sentinel lymph nodes. Is everyone with vulvar cancer a candidate for sentinel lymph nodes? No, we typically reserve that for patients with smaller tumors, less than 4 centimeters, tumors that are unifocal, meaning they're isolated to one site, and patients who on clinical exam don't have any suspicious lymph nodes. And some studies have looked at this and have shown us that, again, the false negative rate, the chances of us missing a lymph node that is involved is still very low, is less than 3%. And there is a lower morbidity shorter hospital stay. So these patients have less complications. We're able to detect the nodes accurately, and it can help us guide treatment. Now, how do sentinel lymph nodes help us guide treatment? That is still the subject of study. One of the first studies looking at this looked at patients who had these criteria for vulvar cancer. They underwent sentinel lymph nodes, and patients who had positive sentinel lymph nodes then underwent a full lymph node dissection. So the rest of the lymph nodes in the groin were removed. And patients who had negative lymph nodes did not undergo any additional therapy. And that study, what we learned from that study is that the sentinel lymph node mapping was accurate. We learned that patients who had positive lymph nodes have a worse prognosis as expected. And one of the questions that came out of that study is, if patients have a positive sentinel lymph node, could we maybe avoid doing a full lymph node dissection, which subjects them to increased risk of complications, and maybe consider radiation? I will defer that conversation to Dr. Lymberis, but what I can tell you is that doing the sentinel lymph nodes provides very valuable information, and we're able to detect lymph node involvement that's quite microscopic, and sometimes that can help guide the mode of therapy after treatment, like, for example, radiation. Ovarian cancer. So moving on to ovarian cancer, surgery and chemotherapy has been the cornerstone of treatment for most ovarian cancers. Before I proceed with my talk, I just want to introduce you to some terminology that we commonly use in GYN oncology. Primary debulking or cytoreductive surgery refers to aggressive surgeries that we do up front in patients who have ovarian cancer before they've received any chemotherapy. Interval cytoreduction or debulking surgery refers to patients who have chemotherapy first, and then they have a surgical procedure, and then the remainder of chemotherapy is delivered after surgery. So these patients have chemotherapy before surgery. Secondary cytoreduction or secondary debulking surgery is a term that we use for patients where we do these aggressive cancer resections for recurrence of their ovarian cancer. We use the term complete cytoreduction or complete debulking. We call that R0. That means that all visible tumor during an ovarian cancer operation is fully resected. We consider optimal cytoreduction or optimal debulking surgery when we leave any tumor implants behind that are 1 centimeter or less in size. And we consider suboptimal surgery for metastatic ovarian cancer when we're unable to resect tumor to less than 1 centimeter. So primary cytoreduction, why does it matter? Because it's been shown that when we can remove all visible tumor, these patients have better survival. So that makes a big difference for us as GYN oncologists. And the extent and the type of surgery that your surgeon selects depends on how far your cancer has spread and your overall general health. Sometimes patients with advanced ovarian cancer can have several organs in their abdomen that are involved, and sometimes these procedures can require very extensive surgeries for us to be able to achieve this complete resection or optimal debulking. Sometimes these patients require removal of their spleens, sometimes that breathing muscle between the lungs and the liver called the diaphragm, or sometimes even removal of portions of the liver in order to achieve complete resection. So how does your surgeon make this decision between doing primary surgery or giving chemotherapy first and then following that with surgery? We have some randomized studies that have compared patients who have these primary ovarian cancer resections to patients who have had chemotherapy first and then an interval resection. The benefits of giving chemotherapy first followed by surgery is that it is associated with higher rates of complete resection or optimal cytoreduction. And studies have shown that there may be lower perioperative morbidity and lower postoperative mortality. But some of the drawbacks, some of the concerns with doing neoadjuvant chemotherapy is that we may be selecting out patients who have clones of cancer that are resistant to chemotherapy. And some of the drawbacks is that some of these ultra radical procedures that I showed in the previous slide may not be available in all parts of the world. The outcomes matter depending on where patients have their surgery. And it's been shown that patients who have their surgery at centers of excellence and surgeons with high volume have better outcomes. This is an example of how your surgeon thinks about the best approach for you. So your surgeon will consider your fitness level. They will review your imaging. And based on those, they will try to make a determination if we think we can remove all of the tumor at the time of surgery. Surgeries often begin by putting a small camera into your abdomen to look. We call that a diagnostic laparoscopy. And there are some scoring systems that have predictive value. Based on what we see at the time of laparoscopy, we can try to predict who is likely to benefit from primary surgery to remove all of the tumor, or with pretty good reliability, we may be able to predict patients who are unlikely to have all their disease resected and who may benefit from receiving chemotherapy first to shrink the cancer before proceeding with surgery. Now, another new development that I'd like to briefly discuss is the development of HIPEC. HIPEC stands for hyperthermic intraperitoneal chemotherapy. So after surgeons perform debulking or cytoreductive surgery, surgeons can put these special catheters into the abdomen that allow infusion of chemotherapy directly into the abdomen. This chemotherapy is heated. The advantages of this is that the heat improves the penetration of the chemotherapy to where the tumors were in the abdomen. The heat increases the sensitivity of the cancer to chemotherapy by impairing its ability to repair its DNA. The heat may induce cellular death. And one of the advantages of this heated intraperitoneal chemotherapy is that it is given once at the time of surgery, as opposed to repeated infusions into the abdomen, which is an approach that we've explored in the past and has shown some survival advantages, but it's been difficult to make this available at all centers to all patients because it is associated with a fair amount of side effects and toxicity. So what is the evidence behind using HIPEC? So we have now very good evidence from studies that have looked at patients who had neoadjuvant chemotherapy and then were taken for surgery, had complete resection of their tumor, and then received chemotherapy before closing the abdomen. And after they recovered from their surgery, they completed their rest of the traditional IV chemo. And this study showed that patients had improvement in survival. So they had longer time until their cancer returned, and their survival overall was improved. So the key points that we have from HIPEC is that in patients who have complete resection of their tumor after neoadjuvant chemotherapy, there appears to be a survival advantage with using HIPEC at the time of interval resection. There was no difference in terms of toxicity, or at least severe toxicities between both arms. And follow-up of these patients, 10-year follow-up confirms that the patients who got this HIPEC at the time of their surgery had improved survival. Now, whether this HIPEC provides the same survival advantage for patients who are undergoing primary surgery without prior chemotherapy, we don't know the answer to that. The results have been a little bit controversial. And whether the results of using HIPEC in recurrent disease, so not for their initial diagnosis, are also a bit mixed. Some of the issues to consider when we do give HIPEC is that it does take longer operative time. It may add at least 2 hours of additional operative time. And, sometimes these patients require ICU care. Now, in the future, there may be something called PIPAC that may become available to patients. You may hear about this at some point in the future. There's still limited data in GYN cancers, but what this means is that there's another way of delivering chemotherapy. It can be delivered in a mist directly into the abdomen rather than infusing this heated therapy. And one of the advantages of this PIPAC, if it turns out to benefit our patients, is that it can be delivered via minimally invasive surgery and that it can be used multiple times. This is something that you may hear about in the upcoming years, but this is still very early. There is an imaging study that we can use similar to sentinel lymph nodes that was approved by the FDA for ovarian cancer. And some of the early studies suggest that when we use these dyes and this imaging study, in about a third of the patients, we may be able to identify tumors or lesions that we would have otherwise missed. So it may improve our ability to ensure complete resection when patients have surgery. At our cancer center, one of the trials that we have ongoing, one of the surgical trials, is looking at patients who get chemotherapy first, and it's comparing whether if we do this surgery with minimally invasive approach with cameras versus an open surgery, whether the outcomes are equal. This study is still enrolling patients, and we have this clinical trial open at our different sites through the NYU Health System. Key takeaways from this is that surgery is safer and more personalized than 2 decades ago. Some techniques, such as minimally invasive surgery or sentinel lymph nodes, help to reduce side effects and speed recovery. An important caution from the LAC trial is that MIS may not be appropriate for all cancers and all patients, so it's important to choose the approach carefully. Some new techniques may not be right for every patient. It is important to personalize care. And I would encourage all the patients who have joined us tonight to always discuss options with your surgeon, and if appropriate, consider second opinions in the management of your gynecologic cancer. Thank you.
That was great, Eddie. Thank you for that incredible review. Really informative and touched on so many of the main changes that we've seen over the years in terms of surgical options. So, when can you avoid full lymph node dissection in endometrial cancer? One of our individuals asked.
Thank you. That's a great question. So we use an algorithm when we inject dye into the uterus, and we follow this because the uterus is a midline structure. It should drain into a sentinel lymph node on the left and on the right side of the pelvis. If we see that there is a sentinel lymph node that only drains on one side, the recommendation is to do a full lymph node dissection on the side where the mapping failed, where we then see that dye get to the sentinel node. Another consideration where we may do full lymphadenectomy is if at the time of surgery we notice that the lymph nodes are grossly involved, they're abnormally enlarged, and we can see that they're involved with tumor. That may be a situation where we consider doing a full lymphadenectomy.
Another question that I think was interesting: how do genetics influence surgical approach in gynecologic cancers?
That is a very interesting question. It's a very sophisticated question, actually. Well, it doesn't necessarily impact. Now, remember that genetics plays little role in cervical cancer, at least to our knowledge to date. So not all gynecologic cancers have a genetic predisposition. And in terms of uterine cancers, probably less than 5 to 6% of uterine cancers actually have a genetic predisposition. In terms of ovarian cancer, that is a little bit different. We probably somewhere in the 15 to 20% of ovarian cancers may have a genetic predisposition. Does this impact what we do surgically? Not necessarily, but I'm sure Dr. Lee will talk about how this may impact what we do after surgery to lower the risk of this cancer coming back.
I'm very excited to introduce our next speaker. This is Dr. Stella Lymberis. And Dr. Lymberis is a clinical associate professor here in the Department of Radiation Oncology. She serves leadership roles as the Director of Quality Initiatives and Gynecologic Oncology Disease Management Group co-lead. She has specialized in the treatment of gynecologic cancers for the past 20 years. In radiation and external beam radiation therapy, as well as brachytherapy. And although she primarily treats gynecologic cancer, she also has expertise in central nervous system, palliative care, and benign indications for radiation. She's pioneered studies in female sexual function and has used sparing techniques to ensure that women maintain sexual function after radiation therapy. She serves as the chair of the education committee for the American Brachytherapy Society. And in the community, she has championed the recognition of women in medicine as the founder of the Dr. Mary Kaluptakis Distinguished Female Physician Award. Without further ado, welcome, Dr. Lymberis.
Thank you, Leslie. I know the Greek name is a little bit of a
Please correct me
challenge, but
now
you
if
did
that's it.
amazing with that.
Thank
Yes.
you. Thank you.
So yes, we're talking about GYN cancers, and as Leslie said, I've been at NYU for a long time. It would be over 20 years, and here in this picture, this is Marie Curie. So I'm going to try to give a little bit of background on radiation. And we do owe the discovery of radium and radioactivity to Madame Marie Curie, who is here pictured in her lab, that you can actually go and visit the actual space and lab at the Marie Curie Museum in Paris. And I highly recommend it if anyone received radiation or has had that in their life. It is a place that goes through and shows the history. Even at that time, radium was used to treat gynecologic cancers in the early 19th century, but we've come a long way. And this is what I wanted to tell my own journey through practicing and using radiation for the treatment of gynecologic cancers over 20 years ago. When I was a resident, we treated the pelvic area of women with a 4-field box technique, which is front, back, right, and left. And it forms a dose that is kind of like a square. You see it here pictured in green. And that was how the treatment was delivered. We have come much further now where our machines can rotate around the patient. So this is the example I took a pic. This is our Variant Edge linear accelerator, and this whole apparatus that delivers the radiation can rotate around the patient. And what that enables in terms of the dose delivery within the patient, even though the radiation is given externally, it can sculpt the dose in a shape. So if you see here now, that green box is converted to the green horseshoe shape as the radiation is being delivered only in the region of the pelvis that we need to treat, which is in this slice, the area of the vaginal cuff, the obturator nodes, and the lymph nodes in this pelvic region. So this has been transformative in reducing side effects to radiation therapy, in able to reduce the volume of the area that we don't need to treat, and really focus on the regions that need to be treated with radiation therapy. So this technique is something you may have heard about, or if you know someone who's received radiation for gynecologic cancers, it's called intensity modulated radiation therapy. So not only does the machine, sort of rotate around, but it also, there is moving blocks that are moving during the delivery of the radiation. So there is a modulation of the intensity of the dose to allow these very sculpted dose regions. And there are times we also use radiation therapy to treat a very, very small target. There are there are indications for using radiation um, for lymph nodes, even local lymph nodes within in regions, sometimes in the abdomen, between the kidneys, that could be difficult or could cause difficult to resect in ovarian cancer or in endometrial cancer. So that's something called stereotactic body radiation therapy, or SBRT. And in those local regions of radiation delivery, that this would be given, let's say 3 or 5 fractions, so only 5 different treatments, and can give very high control rates, upwards of 85–90% within that location. But what I wanted to speak about is the biggest impact in gynecologic cancers from radiation that really correlates with survival is the use of brachytherapy. And I'm going to help and define what that means. So this is now not external radiation, which was the two things I mentioned before. This is internal radiation. It's a little bit more invasive. We deliver from the inside of the tumor, but it's brachytherapy that really impacts on survival and outcome in the treatment of cervical cancer. Here we're talking about cervical cancer. And in the a couple decades ago, there was movement, since we had better techniques to improve our external radiation therapy approaches. People try to omit brachytherapy for the treatment of women, and actually large registry studies, the SEER on the left, and published that the omission of brachytherapy reduced survival. So this was a big detriment to women, and the addition of brachytherapy has a big impact on outcome and control. So let me explain to you why brachytherapy, why it works, and what it is. What does it mean? So brachytherapy, brachis, is from the Greek. The word means short or near. So what it refers to is that we are bringing the radiation source near or within the tumor. So um, we are able this way to reduce the amount of healthy tissue that needs to be exposed to the radiation. We reduce side effects associated with treatment, and we're able to deliver a very high dose of radiation directly to the tumor using applicators, kind of like little straws that the radiation is being delivered within. Another big advance since when I was in training, which was over, I guess, 20 years ago now, was that we also moved from two-dimensional planning of radiation to image-guided, to really where we see the geometry of the tumor, from CAT scan and MR. And that really has also translated to improved outcomes. In the past, we were relying on an X-ray, which was a two-dimensional view of the region, and we were sort of on average taking this arbitrary point called point A, 2 centimeters up and 2 centimeters over, as our prescription point. Our field has had such an improvement and really a revolution in terms of using advanced imaging techniques and actually using those imaging modalities in the planning and the definition of targets and in the delivery of radiation. And that's what's been so exciting, even to me, to see over the last few decades that improvement in our deliveries, improving the odds of cure, the chances of cure, curing more patients, but also reducing side effects. To understand a little bit more about brachytherapy and where the challenges lie, this is a map of the United States, and this is a recent publication, it only, I think 2022, that shows that not all areas, even within the United States, have brachytherapy facilities and abilities to treat patients with brachytherapy within within their counties or states. I don't think we have an actual state that is missing brachytherapy treatment options, but you see that this is the reason, the expertise in brachytherapy and the training involved, and not only the imaging, but also having physics and nursing and amazing GYN oncologists that we work together in the OR, and the whole team that's involved to be able to deliver the radiation effectively and to deliver brachytherapy is something specialized, and it is not and requires the right teamwork and experience and access to these technologies. So how do we begin to assess the patient for treatment with brachytherapy? Well, first, the gynecologic exam is very important, and here we can map out the extent of where the disease extends, and then you'll see on this diagram the staging. FIGO is the staging that we use to classify the extent of the tumor as well. Applicators used in GYN brachytherapy in uterine cancer, we often use a cylinder to treat the vaginal cuff and region to a small dose over a few fractions. And then these other applicators are used in cervical cancer to deliver internally dose specifically to the area of disease. Imaging is what has really revolutionized this field, is what I want to show you some pictures. This is MRI imaging that shows you here in the uterus. It's intense, so it is a little gray area. That is exactly the area of the cervical tumor, and we can see that clearly on MRI. The tumor appears hyperintense and enhancing. And what we delineate is we define the targets, and we have specific definitions of what of the area that we need to treat, the area that it's at risk, and the areas that we can protect. Overall, moving from 2 dimensions, those the simple point based prescription that I talked about, to image-guided brachytherapy, which would be whether CT or MR, translates to a marked reduction in pelvic recurrence from 32% to 7%, and the overall survival to jump from 51 to 86%. There are standardized definitions from the Jack Estro group, and also through the American Brachytherapy Society. We meet and discuss how best we should be delineating these targets and defining these targets. Here you see the tumor seen very clearly on MRI, and this is what we use for planning. And on the next slide, what has also improved is our definition of the normal structures that we really don't want them to get any dose. So the bladder, the rectum, the sigmoid, the small bowel, the other normal structures, which before was, again, a very crude estimate on what those doses they would be receiving these organs in brachytherapy treatments. Now we're very precise, and we're contouring them. We're seeing them on our imaging studies, and we are calculating the doses down to 2 cc's of the target, which is really a very small sliver of the organ that is adjacent to what is receiving from radiation. I can tell you that 20 years ago, when I was a resident, it was not uncommon to meet women that had hemorrhagic cystitis, or basically bleeding complications after treatment from the rectum, from the bladder, and these are not exceedingly rare. They can happen, of course. There could be side effects, but there's a marked reduction in side effects as we have reduced doses to the normal structures, and also because we with our improved imaging capabilities and targeting. So that's really the take-home message I wanted to speak about, is that our modern techniques have improved control rates. Control rates with brachytherapy are upwards 90%, and across all stages, with pelvic control and survival rates improving over 10% with these techniques. There's also been improvement in the staging. We do use imaging for cervical cancer in the FIGO staging of 2018. PET-CT and MRI imaging includes PET scan and MRI definitions, so we can see lymph nodes on PET scan, as well as have the ability to boost this areas of the lymph nodes in our radiation planning. On this slice, I'm showing how in this case, we're treating the pelvis. You see that in the purple, but there's an area of a lymph node in the yellow that is boosted to a higher dose at the same time that other larger volume is getting treated to a lower dose. So we can sort of escalate the dose where it's needed, and again, leave the region in the pelvis to a lower dose. And in this case, the patient would be undergoing daily treatment Monday through Friday for 25 treatments, and would be followed by internal radiation to the cervix to boost the dose to the cervix with brachytherapy. And in this case, for example, on the left, this would be an example of how the tumor would be before we start any radiation, about 5 centimeters in size. And then after delivering those 5 weeks of treatment, it's almost unrecognizable, but there is a faint, about 1.5 centimeter residual disease in the region of the cervix, but a marked reduction by the time we do the brachytherapy. The brachytherapy, the internal radiation, can be delivered with different applicators. This is an example of a ring and tandem applicator that, again, very focally delivers the treatment within the cervix. And by understanding the anatomy better, we also sometimes are placing some needles to carve out dose and be able to deliver dose in the geometric direction that the tumor is lying. So in this case, on the right side, there's no needle in the planning, but on the left, by placing the needle within the tumor posteriorly, which is the backside, we're able to sculpt the dose further away from the bladder and conform the dose of the radiation better to the tumor. Sometimes the areas are more complicated, and meaning that if there is no uterus, or we're treating with brachytherapy a region of disease that is low in the vagina, we might need to place many needles to be able to deliver dose on the aspect here on the left side. The tumor was on the left side, and we can deliver radiation specifically to regions of that are to the side of the vagina. This is called interstitial brachytherapy, where it's basically where the needles are placed in the tissue. So I wanted to just give it that kind of summary, a little bit of how we treat with radiation. We basically look at the disease at the diagnosis, and then we look at the disease at the time of brachytherapy, and we look at the response. And depending on the response, that's how we define the targets that we are treating. So there could be, for instance, disease at diagnosis here could be a large, this oval shape in the axial or coronal on the side of the vagina. And at the time of brachytherapy, it may have responded in a partial manner. And in that case, there is still some red, meaning gross residual disease. So there is disease still active that we feel, perhaps like a little, you might feel like a little rice on the side of the vaginal wall. You might feel the tumor, and you also can visualize it, and that would be your target to boost. Or there might be a complete response, but we still have to give radiation with brachytherapy, even if there is a complete response, even clinically or radiographically, but on imaging, we may not see something because microscopically there'll be disease, but we would treat here a smaller volume and to lower dose. So these are sort of the questions. So if you ever, if you had received radiation, your doctor may have explained to you that, your imaging at the time of diagnosis, at the time, during treatment, or if you were undergoing brachytherapy, what the response is prior, and how that impacts on the planning. Advances that we've made at NYU, I think Leslie brought up a good point. Well, we have been working for many years in designing how we could move to an outpatient program, meaning that usually we do brachytherapy and patients stay in the hospital overnight. And we are also, for the appropriate patients that we can accelerate this and deliver their treatment under anesthesia, but also, reduce the necessity of them staying overnight with the applicator. There are reports of patients having even PTSD or other anxiety, or other complications related to having the applicator in place for multiple days. So we are moving to we've already completed our first patient, and we are moving to offer this more widely for appropriate patients. There are long-term complications still with radiation in general, but specifically with brachytherapy. And these are areas that we are actively also engaged in research. So I'll tell you a little bit about them, but it's very important to know the ovaries are very sensitive to radiation, and so in terms of infertility and ovarian insufficiency after radiation, as well as sexual side effects, vaginal dryness, cystitis, rectal toxicity, and other sort of complications related to radiation. One area that we are innovating here is this picture is actually of a patient where we're demonstrating, if you see the structure in white, that is actually the bulbal clitoris. And in radiation therapy, we've been assessing sexual function, really only looking at endpoints related to the vagina, vaginal stenosis, vaginal length. But in male sexual function assessment for prostate cancer, there's other also aspects of orgasm and other questions that are asked routinely. So we did the first study in GYN cancer, where we studied our patients with undergoing brachytherapy, and we looked at their MRIs, and we delineated the bulbal clitoris, and we reported the dose received to the structure. So this is very exciting, and we're we're presenting this again at ASTRO this weekend. I'm going to ASTRO this weekend, which is our annual meeting in San Francisco, where we're presenting for the first time and proposing the bulbal clitoris as an organ at risk that should be defined and spared in the treatment of women with radiation therapy. And hopefully we can understand better, with better patient-reported outcomes, how to maintain sexual function in a meaningful way to help our patients in the future. We've also looked at the rates of fertility and hormonal preservation amongst our cervical cancer population, looking at all our patients under the age of 50, and looking at aspects related to fertility. This is an example here of a patient that received radiation therapy to the pelvis and periaortic region. So we looked at whether ovarian preservation was feasible, which sometimes it's difficult to do when you're also facing with treatment of a very advanced cervical cancer. But we looked at rates of ovarian transposition, fertility preservation, and other outcomes. And I think we have a lot of room for improvement here to improve the discussions for patients, counseling. There was a patient that with a surrogate with cervical cancer was able to have a gestational surrogate. But I think there is a lot more by, again, publishing these findings and really brainstorming on how to improve the outcomes for our patients. Another area that we could improve and we looked at is also the use of hormonal replacement therapy for our patients with cervical cancer. It is safe to prescribe estrogen for patients that undergo that it's largely a squamous cell carcinoma, that so there is no risk associated with it, with prescribing estrogen replacement therapy. And we know for patients with early menopause, there are adverse long-term outcomes if they're not prescribed hormonal replacement therapy. Now, this is a challenging subset of patients. A lot of those patients are socially disadvantaged, and it's possible that lack of follow-up contributed to the low rates of prescription. But again, I think there's a lot more education that as radiation oncologists that we should also be helping, advising, and being champions for the long-term care of our patients that we treat with cervical cancer. So this is another aspect that we're taking seriously and to discuss further with our colleagues to improve these outcomes. So lastly, there's two more areas of work that we just published a paper on spirituality. And I think, these treatments are very stressful for our women facing gynecologic cancers. And it was very interesting to be to lead this effort of trying to evaluate the importance of faith, belief, and meaning, community for our patients that are undergoing GYN cancer treatments. And it was I think this is an aspect that we can also do better. We found that 10 of 11 patients found that it was important to discuss their attitudes and whether religion and faith and spirituality is important to them. They wanted their practitioner to know about that and that it did help them cope with the illness. So I think this is something we can learn more and listen, engage better our patients to their treatments. Finally, we are in an AI world, so the Chat GPT and information of patient information is something I think also the GYN Oncology group had published as well. But we looked specifically in brachytherapy information related to cervical cancer as compared to prostate cancer, and found that specifically for brachytherapy patient-related information, there was a lot of still some hallucinations and inaccurate information. So I guess my conclusion still to people out there is, talk to your doctor, not the Chat GPT at this point. Finally, we'll close again with Marie Curie, and I would just love this quote that she has, that in the hands of a criminal, radium is very dangerous. So we must ask ourselves, will humanity earn or lose from this discovery? I am one who believes in the former. So yeah, we're using radiation for good. We're trying to be helpful, and we're trying to use, benefit from the improved imaging to improve cures, but also reduce side effects. Thank you.
Asking about newer technologies, MRI-guided RT, proton therapy, and adaptive RT, are they better for GYN cancers?
Oh, that's a great question. So we do have an MR-Linac here at NYU as well. That is adapted, meaning adaptive therapy means for each fraction you plan and you sort of can hone in on the treatment. I think it depends what you're treating. If it's something that is going to move or, might fluctuate, but I think for the standard treatments of our cervical cancer, we are also, or endometrial cancer, or all the tumors that we're treating currently, we are using an image, a cone beam image for each setup to align and make sure that we are accurate on our setup. So we are delivering in an image guided fashion. Now for the protons, that's a different modality of therapy. Proton therapy is very advantageous, especially for the base of skull or different locations. Because there's not as much exits. The protons have a charge particle, so they sort of come in, deposit the dose, but they don't go further. The Bragg peak, they end at a certain depth. Again, I think really, I can't make a general statement about that. I think in re-irradiation, repeat radiation, different locations, there could be an advantage for protons, but you'd have to consult, specifically and get for, depending on the case.
Now, without further ado, I'm going to introduce Dr. Sarah Lee. So Dr. Sarah Lee is an assistant professor here at NYU Langone. She offers minimally invasive and robotic-assisted surgery to patients with gynecologic cancer, as well as good old-fashioned open surgery. Let's not forget that, Dr. Lee. Dr. Lee grew up in Seattle and completed her medical school residency and gynecologic oncology fellowship here at NYU. So she's an NYU lifer, and I can attest to her being a phenomenal clinician and wonderful surgeon, as well as great researcher. So it was really a coup d'etat that we were able to keep her here after her fellowship. And I'm really excited to hear her talk today on advances in gynecologic chemotherapy. Take it away, Dr. Lee.
Well, thank you all for spending the evening with us. I am so excited to be here. For the next 20 minutes, we'll talk about updates in gynecologic cancer therapies, and specifically about anti-cancer medical therapies and how precision medicine has really revolutionized the care that we can provide for patients with gynecologic cancers. I'll start by talking a little bit about the background epidemiology of gynecologic cancers, talk about precision medicine, and highlight some therapeutic innovations that have really changed the way that we care for patients across ovarian, uterine, and cervical cancers, and then we'll conclude. So this may be old news to all, but these are statistics for American Cancer Society incidence and mortality of female cancers for this year. And we can see that on the top right, that uterine cancer is among the top 5 gynecologic cancers, and of all cancers for women in incidence, following breast, lung, and colon. Ovarian cancer is not among the top 10, however, does account for a disproportionate mortality compared to the incidence. You can see that ovarian cancer is 6th after uterine cancer, and cervical cancer overall is a rare cancer compared to the other gynecologic cancers, at least in the United States. Looking at it a little bit differently, ovarian cancer mortality has really decreased in the last 50 years, occurring mostly because of the progress made in the mid-2000s due to platinum chemotherapy. But since over the last 20 years, from 2004 to early 2020s, the death rate declined only slowly, but reflecting both decreased incidence and improved treatment. Uterine cancer, I want to highlight, is one of the few cancers now with increasing mortality, with death rates rising. Previously, ovarian cancer was known to be the gynecologic cancer with the highest level of mortality, but recently uterine cancer has surpassed that due to the rising incidence of aggressive histologies, advanced stages at diagnosis, and these histologies, particularly among Black patients. Cervical cancer mortality has also decreased over time, really due to the prevention and early detection strategies through vaccination programs and screening with Pap tests, although the decline has been slowing down over the last 20 years. But this is truly a cancer that's plagued with disparities. We know that this cancer affects patients who are disadvantaged, and the death rate is higher in Black and Native American women compared to white patients. But there's hope. I'll talk a little bit about what precision medicine is before diving into some spotlight highlights in our cancer therapies. So the standard of care for ovarian cancers, uterine, endometrial, and cervical cancer has really been conventional chemotherapy for decades. And scientists have really suggested that these cytotoxic anti-cancer treatments have reached the ceiling of efficacy. Historically, we have used carboplatin and paclitaxel, commonly known as carbotaxol, as the backbone of treatment for all of these cancers. But recently, emerging medicine, especially precision medicine, has offered new hope and innovation. So the past therapeutic model was that all cancer by sites are the same and treated similarly. So like I said, in gynecologic oncology, carboplatin and paclitaxel, you could think about that as this shape of the treatment has been the treatment that we gave to all patients because we assumed that all cancers were yellow squares, for instance. But we know now that genomically this is not true. So this precision therapeutic model assumes that the origin of the cancers, the tumors are extremely diverse, even within the same type of cancer. So even within uterine cancers, or even within the same histology of uterine cancer. So let's say endometrioid or serous cancers, we know that tumors have a diverse array of drivers and are really heterogeneous. So, so for instance, if the patient's tumor is a green circle, it does not fit the traditional paradigm. So the assumption or the precision medicine concept is that tumors are diverse. They have different drivers, and treating differently based on the specific tumor improves outcome. So the goal is to find out which shape or what type of cancer patients have in a molecular genomic level, understand these drivers, and apply the appropriate therapy for that specific medicine to really help parse out the molecular profile, regardless of the treating organ. So breast cancer has been an early adopter of this for decades with ER/PR testing and HER2 testing. And now with gynecologic cancers, with the advancement of tumor testing, this is an exciting time to treat patients based on their specific molecular drivers of the tumors and not as a blanket based on the tumor type or site origin. So I'll highlight three precision medicine concepts that have really changed the standard of care for our patients with gynecologic cancers. So for ovarian cancers, I'll talk about poly-ADP ribose polymerase inhibition, also commonly known as PARP inhibitors. Endometrial cancers, I'll talk about HER2-directed antibody drug conjugates, which is an exciting class of medications that has revolutionized the care that we provide for patients. And I'll highlight immune checkpoint inhibition or immunotherapy through cervical cancer. Okay, so starting with ovarian cancer. So ovarian cancer survival and outcomes have really stalled over the last 20, 30 years. And the Cancer Genome Atlas has been a landmark research program that really aims to understand the cancer, different cancers at a molecular level across cancers. And this has been a heroic effort collecting tens of thousands of types of tumors across over 30 types of cancers, of which ovarian that you see here in purple. However, no clear molecular patterns are suggested in ovarian cancer, suggesting that there are only a few targets in ovarian cancer. but there's hope. So data have shown that up to 50% of patients harbor mutations in the homologous recombination pathway and have what we call homologous recombination deficiency, or HRD for short. More commonly known are BRCA1 and 2 mutations, and these are a subcategory of mutations involved in the homologous recombination pathway. So at a very high level, these repair mechanisms are high fidelity DNA repair mechanisms. They're basically really good proofreaders for fixing DNA mistakes. And this graphic shows some of these genes that are involved in those repair mechanisms. And the idea is that when your tumor is defective at fixing these DNA repairs, then you're reliant on a more primitive mechanism of fixing DNA through another way, because you can't fix it in the normal high fidelity proofreading way. And this is where PARP inhibitors come in. So basically, because you cannot fix DNA mistakes in the normal way, you're more dependent on a pathway that's more full of errors. So when you block this, when you're missing this, and you also block the way that you can fix DNA more primitively with PARP inhibitors, then you're getting cells that are full of DNA errors, which are not compatible with survival, so that tumor cell dies. So there have been 3 landmark randomized phase 3, which are kind of our highest level evidence trials that have demonstrated the efficacy of PARP inhibitor maintenance therapy for patients with high-grade serous, which is the most common type of ovarian cancer, and endometrial ovarian cancers, and patients with HRD deficient tumors. So I'll go through these studies, but just a quick note on how you find out if you're eligible for one of these mutations. So one of the ways you can be eligible for these mutations or PARP inhibitor treatment is through germline testing, which is basically genetic testing that you do through blood, sometimes saliva. So this is when you find out if you have a mutation like BRCA1 or BRCA2 in your genes. This is something that is hereditary. And if you're found to have one of these mutations, then it's in all of your cells, and this is shared amongst your family members, and you have an increased risk of cancer syndromes. Like if you have BRCA1, you're an increased risk of breast and ovarian cancer. As an aside, most patients are actually diagnosed with these mutations after a cancer diagnosis, but patients that have strong family history of ovarian cancer or other types of cancers are eligible for genetic testing, perhaps earlier for some preventative strategies. Or if you're not undergoing genetic testing, tumor testing is another strategy. So this goes beyond the traditional pathologic testing of just looking at the tumor cells or where the cancer is, looking at stage or histology, and looking specifically at the molecular drivers to see if you have these HRD signatures in a tumor-specific level. And just to clarify, patients with ovarian cancer should be getting one or both. All patients with ovarian cancer should be getting genetic testing to see if they have one of these mutations that are in those syndromes like the BRCA families, and or also getting tumor testing to see if you're eligible for one of these therapies. So SOLO-1 has been a landmark trial. This was a randomized phase 3 study, and to enroll in this study, patients had to have either germline or somatic or tumor BRCA mutations and had to have complete or partial response after receiving chemotherapy and had to be advanced stages. So after receiving carboplatin or carbotaxol-based chemotherapy, patients were randomized to either olaparib, which is a PARP inhibitor taken by mouth twice daily for 2 years, versus a placebo. And this study showed that at 7-year follow-up, there was a significant progression-free survival and a overall survival benefit. And all patients in this study had tumors that harbor BRCA gene mutations, either in their germline genetically or in their tumors. You can see that there was a 45% reduction in the likelihood of death for patients who receive PARP inhibitors in this study. PRIMA is another study that was a randomized phase 3 trial that looked at patients with ovarian cancer, also advanced stage, also had to respond completely or partially after platinum-based chemotherapy. And this one used a different PARP inhibitor called niraparib. This is an oral medication as well, taken once daily for 3 years. And this study, so for instance, this is one of the ways that you could test the tumor for homologous recombination deficiency. So you can't look specifically at which genes are missing. So this is a test that is sent on tumor tissue and basically assesses for, does your tumor show um, or results or effects that are evidence of these bad DNA repair mechanisms and these loss of heterozygosity or telomeric allelic imbalance or large scale state transitions are basically combined into a model, and you get a score out of 10. And this report shows you, does your tumor have homologous recombination deficiency or not? And this study also showed that there was a progression-free difference between patients who were homologous recombination deficient. So 10 months versus 21 months, 22 months for patients who received niraparib if they were had homologous recombination deficiency. But this benefit was more modest for patients on the right here, only 8 months versus 14 months if patients did not have this mutation overall. This is a forest plot that shows basically anything that is on the left of this dotted line. You can see that patients who had the BRCA mutation had the best benefit from receiving this PARP inhibitor. Patients who had the homologous recombination deficiency signatures also did, but the patients who had who did not have either one of these mutations, these precision medicine mutations, did not have as much benefit. Lastly, this is Payola-1, which looked at the addition of olaparib, which is the same PARP inhibitor that patients in SOLO-1, the first study, received. But different in this study, patients also received bevacizumab, which is an IV medication that was previously given as maintenance, meaning after the completion of chemotherapy to lower the risk of recurrence. And again, similar findings. You see that patients who did, patients who had homologous recombination deficiency had sustained overall survival benefits in patients. So 0.6 of hazard ratio for overall survival compared to patients who, in this study, patients who did not have these signatures did not show a difference. So I'll skip this slide. So moving on to endometrial cancer. So HER2 is a growth factor receptor overexpressed on multiple tumor types, not just in uterine cancer. It's a signaling pathway that's related to the KRAS and MAPK growth cascades. And this has been used in breast cancer, trastuzumab, which is an anti-HER2 agent, for many, many years. And we know that this is known to be expressed in immunotherapy in up to 80% of endometrial cancers. And this is tested by immunohistochemistry, which you can kind of see here that these are basically tests done by pathologists to determine the level of expression. So the more brown you see, the higher the expression of this HER2 marker in a patient's tumor, whereas on the right here, you see that there's no uptake of this specific protein. So this is a patient's tumor that showed that there's zero HER2 uptake. So they're graded on a level of 0 to 3. This is this is an example of an antibody drug conjugate, or ADC for short. Has a really fun name, trastuzumab deruxtecan, so TDXD for short. And this has been a very exciting addition to the armamentarium of treatment that we have for patients. So basically the way this works is that it's like a Trojan horse. So this blue is the monoclonal antibody. So this is the delivery vehicle that targets specific tumor cells. So this is the thing that targets HER2, or this is the anti-HER2 agent. But really interesting is that it's linked by this really long linker chain to this payload this is a topoisomerase 1 inhibitor payload that's specific to TDXD. And what the payload is it's the potent drug that essentially kills tumor cells. This is a Trojan horse. And this linker connects the two to make sure that it's stable in the bloodstream, and only is basically cleaved at the tumor site to minimize damage to non-tumor tissue. So these ADCs, the way this is designed, allows us to do two main things. One, it allows us to give higher doses of the treatment or the payload to patients. If this dose was given regular, like a chemo drug, then it would be toxic, very, very toxic. And also because of the specific antibody target, it is able to, the blue here, can't see the blue here, you're able to target specifically to high expressing markers on tumor cells. So for this drug, it's HER2 agents. Destiny Pan-Tumor is a phase 2 study that showed that TDXD was TDXD for multiple types of solid tumors. So just being cognizant of time, I'll speed up a little bit, but this is for patients with multiple types of solid tumors that were not eligible for curative therapy that had received 2 or more lines of therapy previously. And you see that for patients with HER2 IHC3 plus, the response rate was, overall response rate was 85%. A little lower for patients that express a little less, but you can also see that this is carried across multiple tumor types, cervical, ovarian, and other tumor types. This is a case study of a patient that we treated at NYU who had a recurrent refractory uterine cancer. And you can see here that initially her tumor, this is her pre-therapy, and after 15 cycles, you can see complete resolution of this, which was amazing for this patient. And lastly, but certainly not the least, we know that immune checkpoint inhibition therapy has revolutionized oncology, not just in cervical cancer, but across multiple types. And there's been numerous FDA approvals. And essentially the way that immune checkpoint inhibitor therapies work is that it targets this PD-1 or PD-L1 of one of many immune checkpoint inhibitors, but it's basically like an invisibility cloak for tumors. Tumors hide from the body, tumors basically hide from the body ability to detect a foreign invader. So basically these anti-PD-1 or PD-L1 agents uncloak that invisibility cloak to expose the tumor. And for patients with cervical cancer, recurrent disease can be essentially untreatable, but we have seen that pembrolizumab, which is a PD-1 anti-PD-1 antibody, has been FDA approved for recurrent refractory cancer, for recurrent refractory cervical cancer. But not only that, this is a Keynote 826 was a study that showed that the upfront use of pembrolizumab, meaning at the time of diagnosis for advanced metastatic or recurrent cervical cancers in combination with chemotherapy, showed that there was meaningful progression-free and overall survival benefit. Okay, we made it. So the conclusions are that precision medicine is an important trend that holds the promise of personalized medicine. We're no longer treating patients all the same that have the same cancers. And as our testing becomes more robust, patients with gynecologic cancers will be assessed even more broadly for targetable signatures beyond the drugs that we mentioned today. And we have experience supporting the use of molecular testing to identify promising targets, and this will only expand with further development of pipeline agents. Thank you so much. We know that cancer diagnosis and recurrence are some of the worst times for patients, but it's a true privilege to care for patients alongside Dr. Boyd, Dr. Lymberis, and Dr. Jiménez, and all of us at NYU.
What does the BEAT-CC trial mean for first-line cervical cancer treatment? But I'll ask you, Dr. Lee, to broaden that. Can you talk a little bit about the addition of immunotherapy to frontline treatment in cervical cancer?
So I talked about it a little bit at the end, but essentially addition of immunotherapy for cervical cancer frontline, in addition to adding immunotherapy, has really improved progression-free and overall survival. So Keynote 826 is another study that we discussed briefly, but these are patients that have metastatic disease that sometimes are incurable. So adding immunotherapy for patients who 80% express PD-1 has really revolutionized the landscape of treatments that we can offer for patients.